And now I'd like to hand over to Roger Alcock. Please go ahead.
Thank you. So, having looked at what purpose to have a PEWS and looking at the current PEWS charts in Scotland, we've then gone on to look at why we couldn't just use the best one across Scotland. In Chapter 4, what we'd like to look at is, within the context of developing a national PEWS, how do we establish the normal range of observations? Where do we set the limits? So all scoring systems have different ages of charts. One of the challenges is establishing which age groups are best to use. And also, all use different ranges and thresholds for scoring. So how do we identify which is best? Best, of course, refers to the sensitivity and specificity. We obviously need to go back to the literature, and we looked at a lot of literature. A couple of the examples would be from the Lancet in 2011 and Susanna Fleming et al., who produced a systematic review of observational studies looking at the normal ranges of heart rate and respiratory rate in children from birth to 18 years of age. In total, they looked at 69 studies with heart rate data for 143,000 children and respiratory rate data for over 3,500. We also looked at data with regard to blood pressure, and one of the largest studies has over 83,000 observations for more than 60,000 normal children in normal clinical settings. When we then look at this data and plot it in graph form, as Fleming et al. Performed back in 2011, what we can see on these graphs is the way that the respiratory rate, as we know, reduces from birth to the lower levels seen in young adults and adolescents. On this graph, the centiles have been plotted in blue and the median is in green. And what is interesting is that advanced paediatric life support values, which, when you consider all the different life support courses and the values associated with them, has been identified as being one of the best. The ranges chosen, for example, in the case of children under the age of 1, have large numbers of normal children being scored as abnormal because their respiratory rate is more than 40. And the discrepancies continue across the other ages, although to a lesser extent. So what we have attempted to do with the National Paediatric Early Warning Score charts is to use the evidence to tell us what the ranges, the normal ranges, should be. And as you can see here on the chart where we superimposed the national PEWS values, there are some distinct changes, particularly with regard to the younger age groups when comparing to the best in class advanced paediatric life support ranges. Similarly, when we look at heart rate, there are also discrepancies. Again, in this chart here, we can see the heart rate against the different ages on the x-axis, and we can see the blue centile charts with the median in green and the advanced paediatric life support values plotted in red. Again, what we have then gone on to do is to look at how we can plot the National Scottish Paediatric Early Warning Score charts to ensure that normal children values are more clearly and accurately described, such that the abnormal children's values are clearer. Similarly, we have also looked at the heart rate and respiratory rate curves for hospitalised children, and this has helped us to define the suggested cut-off points in each age group for the different centiles. The final component is to consider how we mesh the evidence obtained from the literature together with the pre-existing guidelines that exist for a number of conditions. For example, the SIGN guidelines relating to bronchiolitis, to asthma, and the National Institute for Health and Care Excellence, NICE, and for example, traffic light systems for identifying seriously unwell children